Hello, I'd like to spend a couple moments on managing anticoagulation therapy and dental surgery. You can access this slide deck as I'm trying to condense this talk. With the increasing aging population and increasing number of patients on anticoagulation therapy, dentists are being taught to get PCP approval to mitigate liability as malpractice cases involving anticoagulation therapy interruption or increase. Remember, it's easy for the dentist to stop the anticoagulation therapy, but many times that may not be necessary. I sent this around to Wake County physicians, and pretty much 100% of the people got it wrong. And I'd like to go over that today. And then I asked this follow-up question. And again, you all are not getting as much information as you should in making these decisions. So 95% of people didn't ask for that information, and it's important. So why am I doing this talk? Well, physicians and dentists should be educated how to treat these patients. Physicians are not getting the training they are to make these decisions. My brother just happens to be one of the foremost experts in the country on implants, and he's written these books. Actually, these are the Bibles for implant surgeons around the world. Actually, these things have been translated into dozens of languages. I wrote the medical sections to teach the dentist when to consult you as a PCP, but I haven't done a good job of educating PCPs what they need to know. The litigation in this area is just growing dramatically. Dental implants are one of the more expensive ones, and if they don't get your consent, they're dragging you into this now. The awards are just getting out of control. So the most common procedures in dental, of course, are extraction. We've got 156 plus million Americans missing at least one tooth. Dental implants are right behind that, growing at about 11% a year, over 3 million per year. But you have to understand, these things can be anywhere from minimal to highly invasive, and that's the critical thing. So we're going to see an aging population. What that means is we're going to have older people that are going to be missing teeth. So what that means is we're going to have more dentists that are going to be doing these things. And the barriers to entry to doing these implants has become lower with new technology. So you're going to see a number of GPs doing this. So again, it used to be mainly specialists. Now we're having a lot more GPs do this. So the critical things are all dental surgeries are not the same. Each patient is unique. Each patient will have a different level of tolerance. Each procedure can produce its own unique challenges. Your recommendation requires some analysis of these factors. And this just goes to show you, they're getting very aggressive. They're taking iliac crest going through the mandible. Mandible to mandible. I had that done. It's not very pleasant. Minimal to highly invasive. That's what I want to point out. They're not the same. Every implant is not the same. Every extraction is not the same. So the goal here is that dental surgery encompasses anywhere from minor to more invasive surgery. Simple local hemostatic measures mitigate the risk of bleeding, but the decision to discontinue these before dental surgery must consider the patient, surgical factors, and a risk balance assessment. So other factors to consider: patient's age, smoking status, cause of tooth loss, behavioral issues, potential for bleeding, infection, functional reserve, complexity, invasiveness of the surgical procedure, the length of the surgical procedure, the technical expertise of the dental surgeon, and the comorbid conditions like diabetes, liver disease, kidney disease. Why do these implants fail? They fail mainly because of the jawbone to correctly heal around the implant. And that can be caused by a number of factors, just like you said: smoking, alcohol, low bone density, comorbid conditions. There's drugs that cause this. SSRIs inhibit bone metabolism, interfere with it. So there's like 4 to 6 times the failure rate in SSRI therapy. Biphosphonates, Prolia, osteonecrosis, a big area of litigation right now. And then we've got the steroids and biologics, and then, of course, chemotherapeutic agents. PPIs dramatically change the increase of certain vitamins and nutrients that help in bone metabolism. So there's a much higher incidence of failure of dental implants in these patients. The critical thing is we want to use the ASA classification. ASA 1 being a normal, healthy patient, we don't have to do much with those. It's the ones once we get into the mild systemic disease with diabetes that's controlled, hypertension, obesity. And then these ones in category 3, 4, and 5, these you really have to make sure that you understand the patient's tolerability, the length of the procedure, and other factors that are going into that. It's also critical to understand the bleeding risk. The ones we're going to focus on today were the surgical extractions of more than 3 teeth and dental implant surgery, as those are 2 of the most common. Of course, we still got patients on Coumadin, so we have to talk about that. Again, I asked you guys this question: do you stop this routinely with an INR of 2.5 in a healthy patient? And 58% of you got it wrong. Why'd you get it wrong? Because all the literature in dentistry says that you don't need to stop these anticoagulations therapy with the Coumadin when the INR is less than 3. And most of the studies are going to show when you did stop it, this is when we got into problems. This one, 2673 patients were withdrawn. We had 22 embolic events, 6 fatal events. So the conclusion, serious embolic complications, including death, were 3 times more likely to occur in patients whose anticoagulation therapy was interrupted than were the bleeding complications in patients whose anticoagulation therapy was continued. Dentists should recommend that the therapeutic levels of anticoagulation be continued for patients undergoing dental surgery. This all comes from the dental literature. JAMA kind of did a thing too and said, basically, you're at more risk if you stop these than if you start, than if you continue it. And even if they do have a complication because you continue it, the literature pretty much supports that that's what you need to do. So there are some occasions where you may have to continue this. And of course, in those, you're going to bridge those patients with Lovenox. And then remember, some medications are going to alter your INR. So perioperable infections, you're going to need to make sure the dentist is aware that certain antibiotics could raise that INR. Thrombin inhibitors, this is where there's still a little bit of controversy, mainly because these are pretty new. We're using these more and more. There's no monitoring, fixed doses, short half-lives. These are the ones we're using. Of course, there's Amdexo, which is $55,000 to $60,000 just to stop one bleeding episode. But the consensus is Pradaxa, if your patient's on it, you're going to stop it 1 day for minimal or low bleeding risk, 2 days for a high bleeding risk procedure. And then you're going to restart it at the same dose, 1 day for the low to moderate bleeding risk and 2 days for the higher risk of bleeding. Same thing with the Xarelto, Eliquis, Cerveza. Low to moderate risk, stop 1 day, 2 days for the high bleeding risk procedures. Restart the same dose, again, 1 day after the low to moderate risk procedure and 2 days after the high bleeding risk. If they've got impaired kidney function for Pradaxa, you've got to stop it 1 additional day before, and you've got to add an additional day after before you restart it. You do not have to do this for the Xarelto, Eliquis, or Cerveza. So basically, the DTIs are safe drugs in the terms of bleeding. The possible post-operative bleeding complications are manageable with conventional hemostasis measures. The bridging approach with heparin does not seem to be recommended, but there has to be discussion between the dentist, the PCP, and the specialist in stopping these medicines. There are some newer studies that are showing that we may not have to stop them as quickly. This one's showing in the low-risk dental procedures for bleeding and the moderate risk that basically there wasn't a real change, whether you stopped it or not. There's another study here now on Xarelto that's showing that maybe we could actually just stop it 1 day for these more invasive bleedings. But again, that's not the consensus. The consensus is still the same. 1 to 2 days for low risk. 1 day for low risk, 2 days for high risk, and you restart at the same interval. The antiplatelet agents, even with the newer ones, Effient, Brilinta, single, dual, you're going to see that pretty much the consensus is you do not stop these. Aspirin, 81 milligrams, absolutely. All the dental literature says that you should not stop this. Single versus dual, almost all the studies are showing the same. Single versus dual really doesn't have any increased risk of bleeding, except occasionally when you're using the 325 milligram aspirin. So you don't really stop or alter these. And these are 11 studies that can support that. Aspirin 325, these patients usually are at higher risk because they're on the 325, and sometimes there is a reason that has to be stopped, but that should also be done in consultation with the specialist, the PCP, and the dentist. Again, all these organizations came up with the same thing. These patients that are on antiplatelet therapy for drug-eluting stents, there's really no reason to discontinue prematurely these drugs. So the conclusion, for extractions, the same. Single and multiple dental extractions may be safely performed in single or dual antiplatelet therapy. Just use the local hemostatic measures. So the conclusion, the scientific literature does not support routine discontinuation of these oral coagulation therapy for dental patients. Routine discontinuation can cause unnecessary risk. Each patient and each surgery has to be evaluated separately. And for Coumadin, INR less than 3, pretty much the consensus is you don't need to stop. But you should do that Coumadin, that INR just prior to surgery to make sure they are therapeutic. Many of the dental studies support a similar finding with the single or dual antiplatelet therapy. And then, of course, the DTIs, we're going to stick with the 1 to 2 days prior, depending on the bleeding risk. Where there are medical conditions with the anticoagulation therapy, you have to, and you continue this, you have to make sure the dentist provides for potential excess bleeding and local hemostasis. So any changes has to be a collaboration. The dentist shouldn't stop this on their own. You shouldn't just stop this because you think so. There should be some discussion. Well, how do I handle this? I have this pretty long thing that I send back. It's on a sticker when I get these requests. Basically, section 1 here, puts it back on the dentist to rely on his dental literature. Section 2 pretty much says that the risk and benefits have been explained to the patient. And then Section 3 says each situation is unique and we must consider many factors. I kind of go then, if the dentist does decide to continue, stress the need to have support to stop the bleeding. But then the last statement I put in here, please use your clinical judgment in light of the foregoing. So what do we remember? Each patient is unique. Each dental surgery is unique. Improper management of anticoagulation therapy can create liability. The ADA has come out and said there's strong evidence for the older medicines, warfarin, antiplatelet agents, as well as limited evidence now for these newer direct anticoagulants, that most patients, it is not necessary to alter anticoagulation or antiplatelet therapy prior to dental intervention. So now when we ask you this question, you're going to come up with 81 milligram aspirin. No, we're not going to stop that prematurely. 325, maybe there's case specific. Coumadin, INR less than 3, no. Single, dual antiplatelets, no. DTIs 1 to 2 days prior, restart 1 to 2 days after. Thank you very much.